And thank you all for coming. I appreciate it. I am Dr. Khan, Nadim Khan. Some of you know me. I am a cardiologist and I'm also an electrophysiologist. In other words, I'm an electrician of the heart. So I take care of the short circuits, the slow rates and the fast rates and stuff like that. So, and they are plumbers and they are general contractors. I'm the electrician, okay? So, a lot of, I started here about 6 years ago, and I started the electrophysiology lab in this hospital. And since then, we have done a lot of stuff of taking care of patients in this area. A lot of patients had to go to Tampa or UCH or Tampa General Hospital, and all that stuff is being done here. And we'll do almost all the top line stuff that was originally people had to go all the way down to Tampa to get done. So I am going to talk probably, since we are recording, I'll go through my slides and talk about atrial fibrillation and stuff. But after that, I'm going to stop and I'm going to have you answer. I'm going to answer any of your questions you might have. So have them ready so we can do that. Another resource I want to point out, obviously internet is a good source of information, but another resource I'd like to point out, if you go to my website, floridamedicalclinic.com, okay, and go to cardiology, and there's a picture of me, click on it. I have for my patients a presentation of about 25 minutes that you guys can look at your leisure. You can direct any of your friends or family who have atrial fibrillation to look at that, and they might benefit from what's available for their treatment. Okay, obviously, end of the day, your cardiologist and your physician needs to make a decision of what's good for you along with your informed opinion. So let me start talking about. I'll start talking about atrial fibrillation, which is the most common arrhythmia there is. How am I going to advance it through here? Okay, so this is what I call my job security slide, okay? So atrial fibrillation is not going anywhere. I look at it as end stage of a lot of issues that happen with the heart. We have right now about 2.2 million people in the United States, and as the demographics get older, we expect about 5 million people by 2050 to be having a diagnosis of atrial fibrillation. It increases a lot of burden of stroke. So atrial fibrillation increases the risk of stroke about 6 to 8% compared to population without atrial fibrillation. So that is the biggest thing. If you get out of here today, if preventing a stroke in somebody with atrial fibrillation is the most important thing, okay? After that comes, quality of life and stuff like that. But this is the biggest thing, okay? Next slide, please. And you can see, 60s, 70s, and 80s. As you go along, both in men and women, atrial fibrillation tends to increase, okay? And then it becomes the most common arrhythmia there is, of anybody above the age of 60. Next. I have said that, and we have learned quite a lot in the past 15 years. Next. So what happens? Why do people have atrial fibrillation? So there is a certain genetic component to it. Some of my patients are 30s or 40s, and they have a certain abnormality in the little gates that control the sodium, potassium, magnesium, and calcium channels in the heart cells. Each time the heart beats, there are little tiny gates in the heart cells that open and close. Sometimes they're stuck in the open position or not. All those can predispose to atrial fibrillation. Okay, we're still scratching at the surface of that. But the most common risk factor is getting older. Okay, the second most common risk factor is high blood pressure. Then further down the line comes heart failure, thyroid problems. If you have diabetes, some drugs, alcohol, overuse of alcohol. Somebody has alcoholism. There's a certain phenomenon called a holiday heart. Okay, people go on a fishing trip, they binge on alcohol, and Monday morning they are in atrial fibrillation. So that's called, and there's no real safe limit for alcohol. Caffeine, not so much. I went through most of the stuff. Next. Basically, when somebody comes in, the heart can go fast. We feel that with the pulse. It'll be somewhat irregular. Normal heart will be, if you feel your pulse, it'll be like that. If you have atrial fibrillation, you can feel it. There'll be no rhyme or rhythm to it. It'll be all over the place. Okay, so that is irregular heartbeat. Okay, so that is how you pick it up, and then basically everybody gets an EKG, and we get our information from that. After that, we do an echocardiogram to see if the heart is strong or not, see how the valves are working or not, and then we do some blood work, like check for thyroid hormones, check for your sodium, potassium, all that stuff. Next. And then we can do a stress test to make sure there's no coronary artery blockages. All those the routine tests we do in somebody who has atrial fibrillation. Next. We talked about that. Risk of stroke also goes up just parallel to the incidence of atrial fibrillation. Next. And these are the initial studies. Up to now, up to about 3 years ago, the only real thing we had to prevent a stroke is Coumadin or warfarin. Okay, these are the studies that went to prove the efficacy of the Coumadin. Okay, nowadays we have 3 other new medications: Pradaxa, Eliquis, and Xarelto, which are like Coumadin. Some of them are better than Coumadin in preventing a stroke. We can go into that a little bit later. Okay, next. And in Coumadin, you have to stay in the important zone between 2 and 3. This is called the INR number. Okay, if it is less than 2, it's like wiggling your toes in the water. Okay, it's not really helpful. It's about 3, then your risk of having bleeding problems gets higher. Okay, next. And then there's a scoring system called the CHADS, scoring system. You can see some patients we will decide, okay, we can just aspirin is enough, but some patients we recommend Coumadin. Why we do that? Because as these things get more, somebody who has had a stroke or somebody who has diabetes, and the risk adds up. If we do this scoring system, if somebody's score is 2 or above, then you have to be on a blood thinner, either Coumadin or one of the newer agents, because then the risk of stroke is far higher than the risk of bleeding. We always weigh the risk and benefits. If it is 1 or 0 in this scoring system, then aspirin might be okay. You can choose to be on Coumadin, but aspirin might be okay. Next. We'll go next. There's 3 types of, it's the same thing, but it's a spectrum. Okay, initially it comes paroxysmal. Okay, it comes and goes. Okay, we don't have to do anything. It just comes and goes as it pleases. But as it makes a home for itself in the heart, then it becomes persistent. So somebody has atrial fibrillation, then I have to do something, either give a medicine or shock the heart and get out. But as it becomes or domesticated in the heart, even if I do something, I can't get rid of it. Then it becomes a permanent atrial fibrillation. So that's like a cascade of events, and some people progress rapidly into it. Some people, take several years to go from paroxysmal to permanent atrial fibrillation. Next. And as our knowledge advances, you can see this is a picture of a sheep heart with atrial fibrillation. This is only one of the things. It is almost like, you see this thing here, the arrow, and this shows how the electricity spreads inside the atrium of the heart. It is almost like if you can imagine 7 or 8 electrical tornadoes running around in the top chambers of the heart. The heart is chaotic. It's not squeezing. Normally it should squeeze like that. This one is just wiggling around like that because it's too chaotic of what's going on in the heart. Next. And then those wave fronts, it's like swirling tornadoes running around all over. They clash into each other. Sometimes they collapse. Sometimes they divide into 2. All that stuff happens. Okay, this is what happens in the heart. Next. And about 15 years ago, in France, in Bordeaux, France, we have discovered that the source of this thing starts in the pulmonary veins, the veins that bring blood from the heart, from the lungs to the heart, oxygenated blood from the lungs to the heart. They have muscle sleeves that go into it, and for some reason they act up. Some reason, like high blood pressure and all that stuff we talked about. They just fire like 300 times a minute into the heart, and then it breaks up and it distributes into the heart, and then it keeps on going after that. So this has led to, originally it was an open heart surgery. It's called the Cox surgery, Cox Maze surgery. Okay, what they did was they cut up the heart, you know, go back please. So you see here, what they used to do, they cut up the heart and then sew it back together so that the wafer wouldn't go back and forth and spread all the way around. Okay, please go forward. Next. So this is how it starts. See, this is normal, and then atrial fibrillation starts here. Okay, this is how atrial fibrillation looks on the EKG. Next. Next. See, this is the Cox Maze procedure. See how they cut it up and then sew it back together. Okay, so what I do next, please. We'll do one more. What I do is, you see here, what I do is instead of opening up somebody's chest, I try to do the same thing from the surgery, but I do it through the hooks in the groin. Okay, I go up here. This is the pulmonary vein that is bringing the blood back to the heart, and I go up here, and this is my catheter. And you see here, this is called the lasso catheter, and this is the ablation catheter. That catheter heats at the tip, and what I do is, next slide. What I do is, this is a schematic diagram. These are the pulmonary veins. You see all these red dots here? So I can make, it's almost like spot welding. I can go all the way around and create a barrier for this electricity from bleeding into the heart and tripping the heart into atrial fibrillation. Next. So this is how we have a 3D mapping system here. In fact, we have two different types of them, and this is how it looks. I go one after another, I kind of spot weld and make sure I electrically disconnect. The tube still remains, but electrically I disconnect those two things, okay, so that it doesn't bleed out into electrically and trip the patient into atrial fibrillation. Another thing I want you to notice is if I put a little burn on your skin, it makes a little red welt, okay. Same thing happens in the heart, and sometimes it takes about 3 months for the inflammation to settle down, and that is when we know, okay, the procedure was worked or not and stuff like that, okay. Sometimes the patients can have atrial fibrillation even after this thing. Doesn't mean the procedure failed. There's what is called a blinding period where you want to wait for about 3 months, until we know where we stand. Next. Next. I talked about the blending period. Next. So these are the initial studies that demonstrated that. Next. So what are the complications, okay? It is a pretty involved procedure, okay? So what I'm trying to attempt to do what the surgeons did, with the open heart surgery, okay? So I have to make sure everything is good. One of the biggest risk factors is making a clot, and the clot can fly out to the brain. So what I do to make sure is I keep the patient on blood thinners. I do a CAT scan to make sure there's no clot in the heart, okay? And then while I'm doing the procedure, I give a lot of more blood thinners called heparin. I give that to make sure the clots don't form on my catheters. Then because I tell my patients I can give them blood if they bleed, but I can't give them brain. Okay, so it's very, very imperative for me to prevent a stroke. So bleeding is a complication because you can have because I do it with the blood being thin. You can have groin bleeding. So rarely there can be blood collection around the heart, and that has to, we need to take a needle to it and get the blood out. It's called pericardial effusion. Sometimes we get collateral damage, including the esophagus and phrenic nerve. We take a meticulous, painstaking detail to avoid, we take each one of these, every patient, every procedure with great caution because, we don't want to have a complication like my patients don't. So all of this can happen. Luckily, these things are rare, and we have learned from original people's learning process. And obviously, as medical knowledge improves, we always learn from what happened. These things, the risk of problems was about 3%. When they started off, back in the day, 10, 12 years ago, and now it is much lesser than that. But it can happen, but we pay close attention to that. Next. Next. So the guidelines, okay, you see here, these are the guidelines from all three heart societies. You see, catheter ablation has made it into all forms of patients with atrial fibrillation, because that has become one of the standard ways of taking care of patients. You don't have to fail a drug to do this thing. The next slide, please. Sometimes there are balloons. This is a laser balloon. It hasn't become much, but we don't have it here, but there's something called a cryo balloon where you can put a balloon into the vein and freeze it up and give it a frostbite instead of heating. It's achieving the same thing in a different way. Next. But in general, this is how an ideal patient looks and a less ideal patient looks. It's like anything else. If you come in the early stages, it's easy for me to handle the situation rather than when a lot of water has passed the bridge. So when somebody has come in, so this is what you got to talk to. If you may have your nephews or nieces or brothers and sisters who may be starting into atrial fibrillation, and their physician may be, okay, let's put you on a medicine and let's marinate you for 10 years. Then when they come to me, it gets very hard for me to get rid of it. So this is something that you may want to talk to patients or families around you, and that's what I'm trying to do. I'm trying to educate, spread awareness, and you guys need to carry that back to the community and say, hey, if you have AFib, you got to try to get it fixed sooner, because after that it gets harder for me to do this, both with medications as well as with ablation. But mostly this is in the beginning. If they come in, that's the thing. If somebody has a lot of heart failure, if you have a lot of valve problems, if the atrium is really large or something like that, then it also gets harder. So I will tell you, if I see a patient and they've had a mitral leakage big time or something like that, I would say no, it's not going to work. I would not even offer an ablation to somebody like that. Next. Oh, that's my kids. Okay. All right. So I'll stop here. So if you have any questions, I'll be happy to answer them. Yeah.
I'm on Multac, and my heart rate, like in the mornings, is like 42, 44, 48. Is that normal? Is that okay?
Very commonly, people with atrial fibrillation also have slow heart rates. Okay, it's called tachy-Brady syndrome. Okay, tachy means fast, Brady means slow. So very commonly, that is already there for you. Okay. Then what happens? We try to treat atrial fibrillation with medicines. So Multac kind of lowers your heart rate about 10 beats. Okay. So it all depends on whether you have symptoms of slow heart rate, meaning if you have a lot of tiredness, if you get short of breath when you walk, if you get lightheaded, all those things would make us consider a pacemaker in somebody like you. If not, we just have to watch that. But Multac does slow it about 10 beats.
I'm on Tupro.
Yes, see, all those things will, already you would have had a slow heart rate than somebody who didn't have atrial fibrillation, but when you have medicines on top of that, then it gets slower still.
I was told that I have PVC, and I was a plumber, and I thought PVC was piping.
No, we got an electrical PVC here.
and I wonder if that's similar to atrial fibrillation.
No, sir. So we all have 2 top chambers and 2 bottom chamber. Do we have a little writing thingy? I could do that. But PVC is extra beats. We can get extra beats from the top chamber. They're just single extra beats. So those are called PACs, and PVCs come from the bottom chamber. Okay, those are called PVCs. Okay, premature ventricular contractions. You may or may not have symptoms from it. You may or may not need to do anything about it. Okay, it all depends on what's going on with your heart, and it is entirely different from atrial fibrillation.
I have kind of a low heart rate too.
Yeah, sometimes the medicines we try to treat you will lower it also, just like his.
What is the difference between atrial flutter and atrial fibrillation?
Oh, I need the marker for that one. As soon as she brings it in, I will get it done. Yeah.
I have had 3 ablations, and I went in for a cancer operation in September, and they couldn't do it because I went in the AFib. Now, I shouldn't have another ablation, right?
Sometimes it is like a law of diminishing returns. Okay, sometimes you can break your head at something, and if it is destined to be there, if so much damage has already been done, it gets very hard to get rid of it. And sometimes people who have cancer get cancer chemotherapies. Those will make it happen, make AFib happen. And at some point we have to say, okay, I don't want to do too much, because I show you the list of complications. Okay, and you may do okay with just medication. So it's a decision you will have to.
Medicine. He doesn't know when he goes in April.
Yeah, that's.
I don't even feel it.
So for somebody like you, because if you feel okay and you don't feel it, I can make you feel better. My job as a physician is to make you feel better, make you live longer and healthier. Okay, so if you're already feeling good and don't feel bad and don't know what's happening in the heart, then I can't make you feel any better than that. My other goal is to try to make you live longer and healthier. That I can do with giving you blood thinners if you can tolerate that. Okay, so that would be the idea behind treating you.
You're also
What's the metoprolol?
That is to keep your heart slower.
Slower.
When you go into atrial fibrillation, that to keep your heart slower. Yeah. Let me talk about the flutter and fibrillation. Okay, flutter is like the younger brother of fibrillation. Okay, so this is your heart. You see me do this in my presentation. Okay, so normal electricity starts here. Okay, and goes from here to here, and then it spreads down like that. Okay, the PVCs that you have, they come from here. Okay, from the bottom chamber. Okay. All I'm talking about is from the top chamber, okay? So the AFib comes from here. These are the pulmonary veins that are bringing blood back from the lungs. There's total 4 usually in humans. Sometimes there's 3, sometimes there's 5. But this comes out like this electrically. So what I do is I do this ablation here to stop that electricity from coming in. The tube remains open, but they stop coming in. But if you go into atrial fibrillation, it's like this. It's like several of them running around. Flutter is the same, it happens with the same reason, okay? But flutter is like this big thing. It's like a big short circuit. Usually it happens on the right side, sometimes it happens on the left side, okay? So the ablation for flutter is easier, okay? I can go in, and this is the valve. I can go in and I can make a line here. I can heat a line. This is called ablation for flutter. And that'll take care of it, and there's a good success rate for that, okay? Flutter also predisposes patients to have a stroke, okay? So they will still need blood thinners, but they tend to hang together. If somebody has a flutter, there's a third chance that they will have fibrillation coexisting. Whether I see them at this time, within 6 months to a year, I will see that they will have fibrillation also.
Why does anesthesia or emotion seem to trigger fibrillation?
Yeah, you can't separate the mind from the body. It's not so much anesthesia. The surgical process itself triggers a lot of catecholamines, adrenaline and stuff like that in your system. That triggers atrial fibrillation, okay? Obviously, if you're anxious and stuff like that. But atrial fibrillation sometimes kicks in at nighttime when the heart is slow, okay? A lot of my patients have it at nighttime. They'll wake up with the heart going fast. It's not that they are stressed out. The slowness of the heart, the tachybrady syndrome I'm talking about, the heart is slow at nighttime, that triggers that. After a big meal, okay, you can go into atrial fibrillation. Okay, that kind of stuff, It's not so much just all fast stuff, The slow part also makes the fast part worse. Yes, sir.
I'm also multi,
Yes.
and I've got one doctor that says I need to be on a blood thinner, and the other one says I don't. If you go by that CHADS thing, it doesn't deem it necessary for me to be on a blood thinner. I need to be.
So the CHAD score is to guide us, okay? So if your score is 1, let's say you just have high blood pressure and you're less than the age of 75, nothing else is happening there, okay? So it's okay for you just to be on aspirin, but it's not wrong for you to be on Coumadin or something like that, okay? So what it basically means is your risk of having a stroke is less enough that aspirin might suffice.
My score is 0.
Yeah, so that's what I'm saying. So it doesn't mean somebody like, if you take 100 patients with 0, nobody will have a stroke. Some of them will, maybe 1 or 2% of them will, but I can't, but there's also risk of bleeding. If I put you on Coumadin, there's risk of 1 or 2% of bleeding. So it's a wash. So that's why we don't recommend it right away. So if you do that, you should go with that.
Yeah, I've been on it for almost 3 years. That works great.
Sometimes
Sometimes I do it around procedures to not have any problems around procedures, but usually after like 6 months to a year, we'll take it off based on the CHAD score. Ablation also is not 100%. Okay, nothing is 100%. You have to have no atrium to have no atrial fibrillation. So for that reason, somebody has an ablation, they do okay, but the CHAT score is 3, let's say, they've had a stroke or something in the past, I would not take them off of Coumadin, because you can have, we have had studies as long as 8 years since original, if the patients have done well, we followed them for 8 years, every few years some of them will fall off the bandwagon and develop atrial fibrillation. So there's no guarantees it will not happen. One of your risk factors is getting older, you know, the other option is not good, so.
He was off of Coumadin for a year, thinking that he had the problem corrected.
So
And they didn't know that he didn't until they were wheeling him into surgery, and he went right into AFib.
See, that's what I'm saying.
So they put him back on.
Yes, so there's no guarantee, you know, especially somebody who doesn't feel it.
No.
You know, you could have it for 2 months and not know about it and have a risk, you know, between seeing
Had it for the whole year.
exactly I'm saying, between seeing a doctor between, you know, 6 months or a year or whatever, you could have this and be at risk for that.
Is it normal then, like sometimes I'll go into atrial fib, it might last 30 seconds, sometimes it might last 2-3 hours. And then after, when it's going real fast, then it starts skipping and jumping, and then all of a sudden it'll drop right back into normal. Is that the way?
That's just the way you're feeling. Okay, usually we see that, you know, it starts off here, it spills out, you know, it may come little spurts and bursts and spurts, then it breaks up into this thing, and then it, you know, it can do weird things, okay, in the beginning, okay. But then some people who are in atrial fibrillation all the time don't know all this stuff, you know.
I can feel it in my throat.
That's what I'm saying. So in the beginning it's more likely to feel it, but after you go along for a little while, we give you metoprolol or whatever, you don't feel it much.
So it's a good thing, and if I do go in atrial fib, should I take a Toprol or just,
It's plus and minus, you know, if you take Toprol, you may make it feel less of those jumpiness, but then your morning heart rates would be even slower. You see, it's a double-edged sword. So you have to figure out which one is a bigger problem at this particular time and treat it. So if Multac is not working for you, maybe you can try another medicine, you can try another, you know, you can try an ablation.
Multac works pretty good, I guess. I mean, I only have the atrial fib. I have the skipping irregular heartbeat.
And these medications are not entirely benign. Like, for example, Multac, you got to watch your liver every 6 months, okay? With somebody who's on amiodarone, it's very effective, but you have to watch the lung, thyroid, and liver for that. Sotalol can cause asthma-type symptoms, you know, or heart failure. All of these have their own side effects. So medicines are not, you guys know, are not entirely benign.
Can I get off of it? If I had an ablation, could I get off of it?
It's possible. No guarantees, but it's possible. Yeah. And, or you could, you know, you could try another alternative antiarrhythmic medication.
Do you have alternatives?
Yes, sir. Mm-hmm. Different type of medication like Multac. Yeah.
Do you think there's any particular trigger for atrial fibrillation? Like caffeine or something like that?
Sometimes it is, not so much caffeine, but alcohol, thyroid problems, but I can't tell you exactly what. Sometimes people, if you take a cold drink of water, can trigger it. The esophagus is supplied by the vagus nerve that supplies the heart, and that you know, that can trigger it off. So those are the typical triggers. Okay, if we are good, I'll have to head back. I have a clinic full of patients I got to go back to. All right. If you have any questions, you know, we will do more of this, and we have our support group. Sarah is my technician in the lab, and we have a very good staff here, and she has the support group for devices. But you can come here and address any questions, and she can always bring it back to me, and we can.
Even if you don't have a device, if you want to learn about devices, you can still come to me.
Yeah, you know, it tends to hang together. You know, for example, somebody like you who gets a device, right? They also have atrial fibrillation. Okay, so it's in the general mix of things. It's a general mix of all that I do. Yeah.
A couple of times here lately, I have a little pain right here. It's not pain. It kind of feels like an electrical shock, kind of. It just lasts a second or two. but I've had it about 2 times, and I had heart surgery in 2004. Is that from your heart, or I'm a diabetic too, or could it be neuropathy, or?
That's unlikely to be the heart from what you're describing, but women, diabetics, you don't have to follow the rule. You could have a heart attack without knowing you had a heart attack. Okay, so what you're telling me doesn't sound to me like it, but if somebody has to check you out and talk to more in detail and get the information. There's a lot of stuff in your chest that can hurt. Okay, heart is a lesser cause of chest pain, but we have to worry about it because it can be potentially a bigger problem.
I have an appointment with my cardiologist and my doctor next month,
Oh, good.
so I mean,
All right. Hopefully it's nothing.
I thought I'd wait with them unless it got worse.
All right, you got a second opinion here. All right, guys. So
Thank you.
if that's good, thank you, sir. Thank you for your attention.